Okay, welcome everyone. My name is Faria Khan and I'm the Associate Director for Asian American Studies. I'm honored to welcome our esteemed guest speakers and all of you to the last of the 3 ASAM Fellows Symposia in a series entitled The Foreign Body. As I mentioned last week, this is the first year Asian American Studies has launched the ASAM Fellowship. Our 6 amazing fellows spent the summer of 2020 conducting independent research projects ranging from healthcare to the census to science fiction, as well as examining issues concerning incarceration, mental health, and education. This past fall, each fellow presented their work, and this spring, worked closely with each other to organize these 3 symposia that engaged how the state and greater geopolitical forces have politicized and controlled the foreign body, the Asian American body. This week in particular, we will focus on the impact of violence and discrimination on the well-being of the Asian American body, both physically and psychologically. Perhaps now more than ever, the work that the fellows have done has a sense of urgency. I'm grateful to our guest speakers for joining us and informing us on ways to resist and reimagine access and equity in social policies and practices for all of our communities. I'll turn this over now to our fellows, Tiffany and Nilu.
Thank you, Dr. Khan. My name is Tiffany Tew, and I'm a junior studying psychology at Penn. I will be moderating this event with Nilu Paletti, who is a senior majoring in health and societies here at Penn. We are both members of this year's ASAM Fellows program, and today's symposium was inspired by my and Nilu's independent research projects that we conducted last summer and fall semester. My project examined the psychological impact of the mono-minority myth and its relation to the academic stress and mental health help-seeking attitudes of Asian college students at Penn. My research also addressed the importance of providing greater access to mental health resources and developing culturally sensitive services for Asian individuals. Nilu's project explored the high C-section rates in South India, focusing on the sociocultural factors that have shaped the experiences of childbirth, maternal care, and women's health at large in India. Through provider interviews and research, Nilu was able to learn about the history of maternal care and connect these ideas to experiences in Asian American populations as well. Nilu and I have combined our research interest in Asian American health to put together this panel on healthcare access, quality, and disparities in Asian American communities.
Hi everyone. So throughout this event, we'll be exploring how access to healthcare and the quality of these healthcare services has been shifting and changing in Asian American communities. We also just hope to discuss the systemic disparities that are rooted in our healthcare system that we've seen, even over the past year. And the COVID-19 pandemic has shined a light on many of the problems associated with these problems with healthcare access and quality. And we hope to delve into the ways in which Asian Americans are implicated throughout this all on both a local and a global level. So we'll begin this event by having each of the speakers briefly introduce their work, and you can learn about the amazing things they've each done. And then we'll follow this up with a Q&A moderated by Tiffany and I. And then we'll end with an open Q&A where the audience can input any questions or have any discussions that you guys are willing to have. So if you have any questions throughout the event, please just drop them in the chat, or towards the end, you can just unmute yourself and ask. If anyone's shy of asking, you can always private message Tiffany or I, and we'd be happy to ask those on your behalf. And so overall, we hope to keep this as interactive and engaging as possible. So feel free to jump in at any point or in the last portion of the event.
Thank you, Nilu. Before we begin today, we'd like to acknowledge the events of March 16th and read out loud the ASAM program statement. The devastating shootings in Atlanta follow a dramatic rise in attacks against Asian Americans, as well as a much longer history of anti-Asian attacks in this country. Anti-Asian racism was part of the campaign for managing this pandemic at the highest levels of our government, and it has resulted in murderous violence against the most vulnerable members of our community. Asian Americans have always been treated as the alien other, never fully incorporated into our history books, and denied humanization in this country. The title of our series, The Foreign Body, is a reflection of this fact. Racism inculcated at the highest levels must be fought at every level. The Asian American Studies program was created out of an activist call to defend our community, and we are committed to exposing the history, structure, and culture of anti-Asian racism in America, and most importantly, to demonstrate the power of solidarity.
So with this anti-Asian violence and events going on in our nation, we're very happy that you guys have all joined our conversation today and for participating in this important discussion. And of course, a big thank you to our amazing speakers for sharing their work and experiences with us. We really appreciate having everyone here, and Tiffany and I will now be introducing our speakers.
Dr. Sumi Okazaki is a professor and applied psychology chair in the Department of Applied Psychology at NYU Steinhardt School of Culture, Education, and Human Development. Dr. Okazaki conducts research on the impact of immigration, social and culture change, and race on Asian and Asian American adolescents, emerging adults, and parents within local and transnational contexts. With colleagues in anthropology, education, and developmental psychology, as well as community partners, she has ongoing research projects with urban Chinese American adolescents and immigrant young adults in New York City, Chinese parents and adolescents in Shanghai and Nanjing, China, Korean American and Filipino American adolescents and parents in Chicago, and current and former Korean early study abroad students in New York City, the Philippines, and South Korea. Her most recent book, co-authored with Nancy Albelman, is titled Korean American Families in Immigrant America: How Teens and Parents Navigate Race.
Dr. Suthi Naraset is an associate professor at the Department of Community Health Sciences in the Jonathan and Karen Fielding School of Public Health at UCLA. Her primary area of research is examining the health equity of marginalized populations, including women, children, and migrants, both globally and in the US. Dr. Suthi Naraset is a social epidemiologist focused on community-based participatory approaches to research, and her experiences have spanned domestic and global settings and include assessing the impact of social policies on reducing racial and ethnic health inequalities, reproductive rights and quality of maternity care, contraception and abortion services, and the evaluations of maternal and child health interventions. Currently, Dr. Suthi Naraset is a principal investigator of the BRAVE study, the first study to examine the health status and healthcare utilization of undocumented Asian and Pacific Islander young adults. Using a community-based participatory approach, this mixed method study assesses the impact of social policies, including DACA, on health outcomes. She also works with national reproductive justice organizations to examine how social policies may impact the health of immigrant women and women of color. Additionally, she leads a large study in Kenya and India to improve respectful care and person-centered reproductive health care among low-income women. In 2019, she was named a change maker in family planning by the Society of Family Planning.
Dr. Dalmacio Flores is an assistant professor at the University of Pennsylvania School of Nursing and is a visiting professor at the Center for Research on AIDS at Yale University School of Public Health. He has led several studies that investigate the role of parents in the sexual health education of their adolescent sons who identify as gay, bisexual, and queer. His current research examines how family dynamics within AAPI families impact the sexual identity milestones of LGBTQ+ Asian Americans and their formative experiences with sexual health access and use. With an awareness of the personal and contextual factors that increase sexual minority populations' vulnerability for HIV, STI infection, and poor care-related outcomes, the first study Dr. Flores led investigated the conditions that contributed to the recent HIV infection of young gay men in Atlanta. That study has fueled his subsequent HIV prevention work that includes community education, being a national spokesperson for HIV testing campaigns, and workforce development with around 1,200 nurses across 3 continents. His commitment to HIV/AIDS care and leadership throughout his career includes serving in various leadership roles for the Association of Nurses in AIDS Care. Dr. Flores earned his Ph.D. from Duke University and is also the faculty advisor of APANSA, the Asian Pacific American Nursing Student Association here at Penn. Once again, thank you all for joining and sharing your work with us today. We are very excited to hear about your work regarding healthcare in Asian American communities, and we will first begin with Dr. Sumi Okazaki from NYU.
Okay, thank you so much for inviting me. And I'm going to be sharing my screen just because it's very hard for me to talk about data without visual aids. So bear with me. All right, can everybody see? Yes, okay, great. So before I begin, I just want to acknowledge that I'm a very proud mom of a recent UPenn graduate. My daughter Abby is a 2020 graduate, and now she's a Ph.D. student at University of Chicago. So we have many happy visits to Philadelphia, and even though she's no longer there, we're thinking about trying to get down there to eat at our favorite restaurants and so forth as soon as the travel opens up. So anyway, happy to be here virtually. So today what I want to do is to share a couple of different work research that I've done with Asian American population. And so with the running theme of racism and how that intersects with Asian American lives, teenagers, parents, and adults. And I think, I want to, certainly I think acknowledge the moment in which Asian American lives are, certainly I think being threatened in very physical ways. And I think, every day news of, yet another violent incident against Asian Americans, especially those who are most vulnerable in our community, I think have been weighing on us. And so I'm hoping that we can have a conversation about how, research and scholar activism around these issues might, be part of that conversation in a productive way. So I'm going to begin with, and I'm going to, the first work I'm going to talk about is the book that was published in 2018. And I think I had a happy visit to UPenn I was invited by ASAM to do a reading from the work. And this is work that I did with my lay collaborator, Nancy Abelman, who was a cultural anthropologist who spoke fluent Korean, Japanese, and many other languages, but she was a specialist of East Asian cultural anthropology and particularly Korean diaspora, including Korean Americans. And so she and I did this work together that culminated in a book-length work. And where we started with this work is that Nancy and I met soon after I arrived at the University of Illinois campus in, I want to say like 1999, something like that. And we began, because we were mutually interested in sort of how Korean American, college students at the University of Illinois were, I think, grappling with the issue of immigration and mental health. And so Nancy had been writing a book at the time that I met her on how Korean American college students and their family network were thinking about what it meant to succeed in America through education mobility. And so she and I started talking, and we ended up doing our first study together on campus, just looking at University of Illinois undergraduate students. And the long and short end of it was that we ended up, kind of finding that the college students were, narrating a lot of hardships of growing up in immigrant parents who were often, working long hours as small entrepreneurs and were not quite able to be involved intimately in their lives. And, in that narration, we also detected, sort of the inflection of being Korean as also a, sort of a negative aspect of their upbringing. And which isn't to say that many had, felt that their families were experiences were negative, that even, despite the hardships, a lot of times they would say things like, oh, but my parents were not typical Koreans. You know, my parents were warm, they're supportive, they, were, friendly and things like that. And so we were kind of paying attention to like, what was it about sort of that kind of narration of, marking their ethnicity as, something to be negated. And yet at the same time, most of the college students that we talked to were finding ways to redeem their family through empathy and understanding. And so we were interested in kind of going where the action was, so to speak. And so we got some funding to go to Chicago, where many of the, there was a large Korean American community in the suburbs. And we wanted to approach the question of, parent resilience despite family turmoil. While the adolescents were living with their families. And so we ended up doing a mixed method interdisciplinary study that started with the field work, where we went to many neighborhoods and just kind of hung out in places where Korean Americans were congregating. We went to a lot of churches and church luncheons and retreats and church PTA meetings. We also got access to one of the high schools that had a large Korean American student population. We did a survey of 186 teens, and about 97, or about half the parents also participated. And from that survey, we selected about a dozen families, 5 families that ended up kind of sticking with us throughout the project. And because of the nature of the family ethnography and the fact that Nancy and I were just kind of working on multiple projects together and separately. So we ended up kind of not finishing the project for so many years that we kept going back to the families, year after year, just to kind of get an update. And so it ended up being an inadvertently longitudinal project where we followed these 5 families over the course of 8 years, from high school into early adulthood. And because our focus is on mental health, what we found in terms of the survey study was that, whereas the previous study of Korean American students on college campuses, we didn't find a significant correlation between how their own depression and how their satisfaction with family. But with adolescents, there was a fairly sizable correlation between depression and family. So we knew that there was something going on with between the adolescents and parents in terms of how they were negotiating that space. And so the 5 families, which make up the bulk of the book, it's a real storytelling of the 5 families that are quite, approaching the project of immigration and race from different perspectives. We had both boys and girls that we followed, spanning about 3 years of, high school age. And each family kind of taught us different things about how they were approaching, navigating adolescence and parenting through, the lens of race. And the family that I'm going to focus on just in a few minutes is this family whose boy, the central boy that we followed, we gave him the pseudonym Ben. And the parents who were at the time that we began this, or at the time of the family interview, were operating a dry cleaner. And that, is a very ethnic, sector especially in Chicagoland, but I suspect in many other parts of the country, where many Korean Americans were investing in or working at dry cleaning business. So it's very hard to summarize a book-length manuscript, so I'm just gonna read a paragraph or two just to kind of give you a flavor of the kinds of racism that the parents and kids are narrating. So this is about Ben, whose encounter with our research team began because the mother approached our team after a Korean church PTA meeting, just kind of asking us, because she knew that we were a team of psychology and anthropologists, we can advise her about her son, where she was very concerned that he was seeing himself as racially inferior. Okay, so over the course of our research engagement with Ben's mother that year and in the following years, she returned occasionally to the observations she shared that day, but more often she spoke of the general matter of Ben's well-being in the United States. It was above all Ben's psychological well-being that, time and again, most seemed to concern Mrs. Coe. She was enormously worried about his future, anguishing in particular over whether he had what it took, constitution-wise, to make it in America. Mrs. Coe went so far as to venture a diagnosis that Ben's retiring manner and lack of self-confidence were inextricably tied to what she viewed as ethnic self-loathing, especially prevalent among Asian American boys, according to Mrs. Coe, and that his low ethnic self-regard was born from his experience of racism against immigrants in the United States. And this family, because they were operating dry cleaning business in predominantly white suburbs, the parents had a lot of stories about just sort of feeling, dehumanized and treated as less than by, their customers. Mrs. Coe also described, her rocky relationship with her neighbors. I'm going to read just one more paragraph around that. Mrs. Coe described her tenuous relationship with the predominantly white and she thought Jewish neighborhood when she moved into her East Creek home 3.5 years before we met the family. She went to pains to visit and deliver ice cream to her new neighbors, a gesture that she thought would work similarly in both South Korea and the United States. One neighbor woman refused to come to the door, ostensibly because she was busy with the children. Mrs. Coe, however, took this as a personal affront. And although Ben and the younger brother eventually became friendly with the children from the house, Mrs. Coe told us that the parents continued to refuse to greet her on the street. She took a moment to share a detail that one of our ethnographers revealed the burden of her own defenses and intermittent seething as she managed her daily life in the suburbs. Quote, "When I see those kids, I mutter, 'those brats' in Korean." She also shared stories of overt racism, such as another Korean American neighbor's front door being egged and her own front door having had ice cream hurled at it, an incident that she reported to the police, who agreed that it had been a racially motivated incident. And so the book, of course, follows this family through different, aspects of the parents' anguish over racial, parenting for racialized America. And some of the takeaways from the book in terms of race and racism that, not only this family, but many other Korean American families were contending with is just how much psychic energy and labor it was, and the toll of, parents' experiences with daily racism that, took up their headspace and had, worried them, had distressed them. They struggled quite a bit over and sometimes fought with kids about how to best, strategize to raise them in the, for the racial realities of the United States. And different, families took different tacks. Some families really thought that they needed to boost, the kids' self-confidence through sports or through music or by being ensconced in ethnic communities and being able to take up leadership roles within Korean American communities. Other families thought that they needed to place the kids into white context as much as possible to kind of harden them to face the realities of racism. So the next study that I'm going to quickly touch on is quite a different study. This is an experimental study that my former mentee, Gloria Wong Padung-Pat, who is now a professor at UNLV in psychology department, conducted, where we were just kind of interested in like how much does racial microaggression, such as Asian Americans being asked about their complimented on their English ability or being asked where are you from, how much do those microaggressions actually show up in what we, psychologists see as, signs of stress. And so it was an experimental study in which Asian American college student participants were faced with either white or Asian Confederates, meaning people who were kind of posing as an, experimenter or posing as a experimenter and had been coached to deliver, a particular kind of racial microaggression by asking the participants, do you speak English? Is English your first language? Making them read a consent form aloud just to make sure before letting them, proceed with the study. And so that microaggression was quite effective in inducing stress, which we measured both self-report and physiologically. And it made a difference that the perpetrator, the Confederate, was white or Asian. The Asian American, all Asian American subjects in this study, the white American perpetrators who, asked them about their English language skills, had much more, had made them much more stressed physiologically than Asian American perpetrators who said the same, asked the same questions about English language skills. And this pathway between perpetrator race and physiological stress was mediated partially through implicit self-esteem, meaning that we kind of tested this hypothesis that being asked by whites to kind of, explain themselves in terms of English and having to demonstrate their English language skills, even if it's not felt, explicitly in terms of, oh, this is making me feel bad, and they might not report that it definitely decreased, implicitly at the subconscious level as we could measure experimentally their self-esteem, which in turn seemed to be sort of related to physiological stress. So that was another study in which we had demonstrated that, racism weighs on Asian Americans in, stress reactions and in terms of depression in many different ways. I'm going to stop here and hopefully during the Q&A, I can share a little bit more about the current ongoing work that my colleague Doris Cheng and I are doing at NYU, looking at anti-Asian racism that's been happening during COVID and the impact on mental health. So stop sharing my screen and stop there.
Great, thank you so much. I can start sharing Dr. Suthi Naraset's slides.
Thanks so much, Nilo. Maybe as you're...
Oh, Dr. Naraset, you're muted right now.
Oh, thank you. Can you hear me now?
Yeah, we can hear you now.
Thanks, Tiffany. So I'll just reintroduce myself again. I'm Mesa Naraset. I'm an associate professor in the School of Public Health.
Oh, you were muted again.
I know, why? Okay, here I am. I just wanted to say how grateful I am for this space and all of your efforts to putting this together, especially given the recent events and constant news reports and trying to process all of that. So I'm really grateful for this community, actually. It's not lost on me that the victims of the Atlanta shooting were women, immigrant, working massage centers, given that existing data suggests that women are 2.3 times more likely to report hate incidents compared to men. This reflects the racialized sexism and how Asian women face public safety issues in general. This issue is certainly not new, but has been exacerbated by the pandemic. So I wanted to acknowledge that. Thank you again for inviting me to speak today for the ASAM Fellows Symposium. My work centers at the intersection of reproductive rights, immigration, and gender. I'm particularly interested in women and migrant populations, partly due to my own background. So as way of introduction, I'm a product of 4 generations of migrant women spanning Indonesia, China, Thailand, and then the United States. Growing up, I witnessed the challenges of my own mother facing reproductive health, having to work in her store selling groceries, basically 2 days after having a C-section, lacking access needed care, facing harassment and discrimination constantly, but also the strength of our communities. And this is really what's led me to the work that I do today. I really take a public health perspective and lens as well to my work, as you'll see. Next slide, please, Nilo. So my work takes a health equity lens, particularly asking questions of who is discounted, disrespected, dismissed, devalued, and dehumanized, particularly in the context of healthcare settings. I wanted to discuss 2 scopes of work that I'm working on. So one in the global setting and then one in the US, really to provide examples of how and why Asian women are mistreated, and to demonstrate with these 2 studies that the same dynamics that allow women to be mistreated and violated in a healthcare setting are the same mechanisms that allow women to work in unsafe conditions, to not be able to pull themselves out of poverty, or to care for their families in a safe environment, to continue to allow for the dehumanization and disrespect of Asian women. Power inequities related to gender, class, and women, and how women are valued and devalued in our society are really at the root of all of these issues. So I wanted to give an overview of 2 of my projects and as an example of my work. So one on the mistreatment of women during maternity care, particularly in the context of childbirth in India. And the second study I'll discuss is on the health status of undocumented Asian Pacific Islanders. Next slide, please. Through these projects, I'll show that when a pregnant woman is mistreated during delivery, or when an immigrant is denied basic health access, it shows us how health systems are often a reflection of much deeper dynamics of power and inequities in societies and the context in which they are embedded. This includes women's subordinate position in society compared to men, discrimination of migrants in our society, and how there is a devaluation of lives of certain population that ultimately drives inappropriate allocation of resources. Across these 2 projects, power is the ability to influence or control behaviors. And in this, the context of this talk refers to the influence of communities, providers, health systems, or even government in controlling women's bodies. My first study in 2015, I began a study in India. Despite major gains in maternal and child health globally, maternal and newborn deaths remain unacceptably high. Much of the maternal health literature is focused on things like health infrastructure, increased availability, access to facility-based deliveries. But the issue of quality of care and how women are treated in facilities has largely been neglected, particularly examining the intersections of class and gender. My work focuses in Uttar Pradesh, and this is the most populous state in India with over 166 million people. Just to give you a little bit of the context of the state, there's lower literacy rates compared to the national average. There's a high slum dwelling population in Uttar Pradesh. Uttar Pradesh also experiences higher maternal mortality compared to the national average. And so based on that, I conducted a mixed method study, both quantitative as well as qualitative, particularly among slum dwellers. And with some of this data, I'll be including some of the quantitative surveys that I conducted with 759 respondents, but we also collected qualitative data as well. We really focused in Lucknow City in Uttar Pradesh. So if you can go to the next slide. So we asked 11 different types of mistreatment during childbirth and labor and delivery. My research found that if you can click again, that 57% reported some form of mistreatment. Other studies have found lower rates, and our study actually really amplified kind of the mistreatment and violence that women are experiencing. So these are the top 5 types of mistreatment during labor and delivery that women describe. So almost 30% of women report being verbally abused. 25% reported requesting a bribe, which, I've conducted studies in other parts of Asia and Africa as well. And I have to say that 25% was particularly high in India. We've done this across India as well and have found kind of similarly high levels of requesting bribes. This seems to be more normative in this society compared to other contexts that I've looked at. I wanted to share a really quick quote about requesting bribes to give you a sense of like what that actually means. So one woman described, when my sister-in-law delivered, the staff there started asking for money. They were asking for money because my sister-in-law had delivered a baby boy. They exchanged our baby boy with a girl. We had to pay more than 500 rupees to get my baby back and get discharged. So this highlights what a bribe might look like. This instance is probably one of the more overt forms of what a bribe looks like, but reflects the gender norms in this society, one that prioritizes sons over daughters. And, you know, I quote that 500 rupees, but women also talked about, you know, there's many instances where bribes are taken. So when you get to the facility, typically there's like a security officer who might ask for a bribe, then the providers, then there's cleaners, then there's the support staff. And so if you're a slum dweller making about 100 to 150 rupees a day, 500 rupees across many of these times becomes quite detrimental to one's economic security. The rest, you know, not being allowed a companion, feeling discriminated against. 15% reported physical abuse during child labor and delivery. So this includes being gagged, hit, slapped, or pushed down during delivery. The next slide gives you a sense of other types of mistreatment. So these are less prevalent, but still, you know, hovering around anywhere from 5 to 10%. So threats to withhold treatment if they haven't paid, for example, being abandoned completely during labor and delivery, delivering alone, denied choice of delivery position, lacking information, and then unnecessary separation from babies. So this just gives you a snapshot of the type of quality of care that women are reporting in this specific context. So a natural important question is to ask, why are women mistreated? Mistreatment is fundamentally an issue of low status women, particularly young, poor, ethnic minorities. Women's mistreatment also contributes to maternal deaths due to substandard care. You can probably see the parallels in the US context as well. There are a variety of reasons why women are mistreated. At the provider level, participants describe how providers typically set expectations and norms regarding behaviors in facilities. Patients with lower social standings may not always understand standard practices. So one woman reports of the physical mistreatment that she had experienced. This is our fault, not the doctors. We don't know many things. If we are literate and know how to read, we would be able to identify different directions given at hospitals. So I think this is important because patients actually blame themselves for their lack of knowledge, rather than recognizing that providers may improve communication to better inform patients of their choices and care processes. So such attitudes creates these power dynamics between providers and migrants that leads to abuse of patients. But providers should not be blamed either. That is not what I'm saying. Providers are often overworked, under-resourced, have poor infrastructures to support them. They are also working within power dynamics. These dynamics point to the failure of healthcare systems to adequately provide resources and support for women, to deliver with dignity. And it highlights the need to further examine gender and violence norms and women's role in society. These dynamics are the ones that I see in my work with undocumented immigrants in the US as well. This is not just a global issue. According to the Listening to Mothers survey, this is a national survey, but also one that was conducted in California. API women were often the subject of unfair treatment during childbirth, with 10% being handled roughly or experienced rude and threatening language from their healthcare providers. So this is within the United States. I'm going to switch gears a little bit to discuss my work with Asian Pacific Islander undocumented immigrants in the United States as well. You can actually go to the next slide, maybe. Okay, great. So overwhelmingly, migration research in the U.S. has focused on Latinx immigrants, kind of from a health perspective, and has really failed to highlight the heterogeneity of the 1.7 million API undocumented experiences, including access to care, immigrant trajectories, challenges in applying for DACA. There's data, for example, that shows that about a third of API documented eligibles are applying compared to almost 80% of Latinx. So there's a huge disparity there. For those who don't know what DACA is, it's a policy that defers deportation and grants a renewable work permit for 2 years for eligible undocumented immigrants. Nationally, APIs make up 11% of the undocumented population. This makes APIs a growing and significant population in immigration and health reform debates. Yet there's a critical lack of information about the health status and healthcare needs of the API undocumented community. Because of that, I launched the BRAVE study. So this stands for Building Community, Raising Asian Pacific Islander Voices for Health Equity. This was the first study to investigate the health status and utilization patterns of undocumented API youth living in California, and specifically trying to understand the impacts of DACA on health. This used community-based participatory research methods, both quantitative and qualitative. We started in 2015, and over a number of different cycles of internet-based surveys now, we've conducted a series with over 800 undocumented young adults. We've also done some community social mapping, some key informant interviews, as well as qualitative interviews with API and Latinx undocumented as well. From the qualitative, what we find is that there's stories from undocumented API that indicate that participants reported feeling a sense of isolation and exclusion, not only from larger socio-political discussions, but also from their own communities. Stories of failed petitions, excessive legal bureaucracy, coercion, and labor exploitation illustrates the distrust in various institutions and even within their own API community. This distrust resulted in fear of deportation and stigma and shame, causing many to keep silent and be less likely to seek help from community resources. This isolation leads to stigma, fear of deportation, and ultimately delay in healthcare. Many reported incidents with their family and their own health of foregoing medical care, despite urgent and acute situations due to fears of cost and disclosing their status. It's also important to acknowledge not only the physical, but also the emotional and mental stress that API undocumented youth face in regards to health care and health challenges. So this data here is actually from our data that was collected in 2019 among Asian Pacific Islanders. So kind of really quickly, let's see. So just to give you a sense, 61% of undocumented women reported clinical levels of depression compared to 52% of men. So this is using the CESD score, and we made it a binary outcome because the kind of the distribution tended to skew very high, actually. Women were also more likely to report suicidal thoughts, yet less likely to seek professional mental health advice compared to men. And then can you go to the next slide? When we look at immigration enforcement by gender, we found that 56% of women indicated that they did not apply for public services due to immigration status. This is a result of the public charge rule. 50% experienced raid or knew someone who experienced a raid. 43% know of someone who had been detained or deported. And 58% reported that their documentation status had limited their contacts with others. These are pretty high percentages. Undocumented immigrant women in particular also reported feeling anxious or sad when discussing immigration, while more than 82% reported fearing deportation some or most of the time. It's not surprising, I don't include the results here, but it's not surprising that deferred action decreased depression and mental health outcomes. I think that this has been shown over and over again in the literature, while immigration enforcement experience and actions have increased mental health and depression scores. Can you go to the next slide, please? But ultimately, for me, what is most important from the work has been the stories among the young people themselves. And this is from a female participant whose mother had actually gone in an accident. She was crossing the street and got hit by a car, did not have health care insurance, and so was unable to get adequate health services, actually. So I'm just going to go ahead and read the quote to you. So she says, people would always talk about the American dream. What is it? You have people living here in the United States, but there's no American dream for them. There were times where I would sometimes I would just kind of let my mom scream herself to sleep, scream her pain. But I would kind of lay awake there crying and wish, like, why can't I have that house? Why can't I have that white picket fence? Why can't I have the green grass? Why can't my family have the benefit of getting health care? And her experiences reflect a deeper dynamic of power inequities and others who have suffered similar experiences due to structural failures in government and health systems. Her mother's social status, her own documentation status ended up causing psychological issues for this young girl. It highlights how health inequities are produced and reproduced across generations, across families and individuals. It also highlights the importance of social determinants, understanding how they interact with health, and ultimately that we need to focus on the structural factors to break cycles of inequities. And that's all I have for you. Thank you so much.
Thank you so much for that. That was really great to hear. I think Dr. Flores is going to share his own slides. So.
Can you see my slides?
Yeah.
All right. So hi, everyone. Thanks again for the invitation to be here. I'm looking at the roster and of participants, and I want to say shout out to all the Harnwell folks who are on here. I think they're a third of our participants. So in the next 10 to 15 minutes, I'm just going to quickly share with you the work that I've been doing out of the School of Nursing. The first part really focusing on the general work on parent-child sex communication with LGBTQ adolescents. And then the latter half, I want to focus on the emerging data that's a subset, which are focused on AAPI participants. Full disclosure, I had not really intended to have my research be focused on AAPI families, but the way we're getting engagement with members of the population has really inspired for me and my team to head in that direction. I'm almost hesitant to go in there because of my primary research interest, but for several factors, the health inequity issues that our population is facing really does not afford me much reason to resist this data emerging and me following it. Essentially, I am a nurse by background. I was born in the Philippines and trained as a nurse here in the States. And as a second degree nurse, my initial job was in Atlanta, taking care of people with HIV and AIDS. And I worked for a few years on an AIDS unit in Atlanta. And so here you just have a smattering of pictures from that initial part of my career. When I got tired of bedside care, because seemingly we kept getting young people coming in on a regular basis with what was called then as full-blown AIDS, I began to wonder why it is that seemingly our public health messaging for folks in the South were failing these youth. I remember growing up in the Philippines, in 5th grade, hearing about HIV from my science teacher. And really, that was the first time that HIV was equated with being gay. And it was really a horrific way to be introduced to the population as a young gay person myself. And so it was shrouded, my initial framing of HIV was already very negative towards the identity that I also happened to be a member of or claim to. So I was thinking, why is it, fast forward here in the United States, that my peers, essentially they were my age, were coming in and seemingly not aware of how to prevent from getting HIV and AIDS. And so I began asking them questions about what led to their recent infections. And through conversations with them, it turns out that while the temperature regarding LGBTQ acceptance has improved through the decades, and you'll see here a bunch of Time magazine covers that show the progression of how Initially in the 60s, being gay was seen as like a nefarious thing, something to be scared about, a gay man lurking in the shadows. Consistently through the decades, there's been some improvement there. But seemingly, the educational needs of LGBTQ people were not keeping up with this social acceptance that was happening. And so, from my patients, they were essentially telling me that, you know what, as we were growing up, we did not get socialized into our sexual roles the way that our heterosexual peers were. The messaging that they were getting in school, in general society, was not attuned to potential same-sex behavior, attractions, or identities. And so that's how I ended up looking at how it is that LGBTQ youth come of age. We have awareness that parents are becoming more accepting. And so here's a cover from, or here's an article from New York Times 2 years ago, where really the norms for parenting is seemingly being upended. There's a revision on parental roles, given that more parents are being, more accepting. How do you navigate when your son, who came out to you as gay at 10 years old, wants to have a sleepover with his best friend who happens to be male? Seemingly, while the initial concern for issues such as pregnancy are no longer there, there are other issues that come about to take the place of that concern. And so parents are starting to grapple with how is it that we can provide inclusive parenting practices. And so I started looking at parent-child sex communication. And this process, essentially, the talk about the birds and the bees. We have been looking at this for 40 years. The School of Nursing at Penn actually has played a pivotal role in identifying just how useful effective communication about sex is. From studies that was conducted by our dean and other faculty, we know that if parents talk to their kids consistently about sex, those young people will eventually enhance their efficacy with condom use. It encourages youth resistance when they are being pressured by their peers to have sex, and it initializes for them to have conversations about HIV prevention before actually engaging in sex. For me as a nurse, and I'm the biggest healthcare access nerd, my favorite point is this last bullet, where if parents do talk to their kids about sexuality, it increases an adolescent's tendency to access and to use reproductive and sexual health services. So this is established science, but that is science that's based on parents who are heterosexual with presumably heterosexual kids. What do we know about parents who so happen to have kids who are LGBTQ? We don't know if those same protective effects are can be observed. And you see here's a screenshot of the CDC website of evidence-based practices, and there's a long laundry list, 100 something interventions that have been empirically proven to work, but there's not one for families with LGBTQ adolescents. And so that's the work that we've been doing at the School of Nursing. I conducted my dissertation with 30 gay, bi, and queer males regarding the nature of sex communication. And what I found out was that these are the topics right here, from dating and relationships all the way to vaginal sex, that when we rank them, were most commonly discussed by parents with their gay, bi, and straight adolescents before these guys came out as being gay, bi, or queer. And then after they came out, so the finding there is that essentially kids are assumed to be heterosexual unless proven otherwise. It's such a secondary notion, perhaps, the potential for a child to be gay, bi, or queer. And so sexuality education and desire, these conversations are missing after all these years. And so if no one guides you through this forbidden world of pleasure, desire, or taking care of yourself, where do you turn to for instruction? And that's where we're thinking is a point of intervention with these youth. When we asked them what were the topics that are commonly talked about after you came out, they essentially told us that, you know what, parents freak out because now that these parents know that their son is actually gay, bi, or queer, they go into the narrative of, oh my God, you're gay. I'm going to talk to you about HIV. That's the one thing that always pops up in their mind. And um, these are reactive conversations. So think about, when you're finally trying to give information that you think is crucial, but it's happening at a time of family distress, there's not much communication that actually happens because both parties are on edge and kids are not in a place where they can take in this kind of tailored or targeted messages that parents who are freaking out is trying to provide to them. When we ask them, though, ultimately, out of folks in the ecological system or your larger society, who would your preferred source be for targeted gay, bi, and queer specific sex education? Consistently, our participants still said, you know what, we want to hear it from our parents. And so our finding from that study is that sex communication or the inclusiveness of it is actually proxy for parental acceptance. And so while I was looking at physical health, which is HIV and STI outcomes, there was the other half, which was really more concerned about the mental health of this population. And so they were asking, can we please not have some kind of parental recalibration where parents are not just talking about heterosexuality and the assumptions that come with that, but provide us, not this narrative of you meeting your princess someday and happily getting married. What about the potential of me meeting my prince someday and us getting married? So that was essentially, in a nutshell, what got us started in this work. And so from 2 years ago, we started building a resource for parents where they can learn about the topics that are specific that are being requested by gay, bi, and queer males. Because straight parents will traditionally go into their basket of knowledge that is based on heterosexuality. Let's try to provide them another basket that they can use when they're talking with sons who happen to be gay, bi, and queer. And so this is my secondary shout out to Andre, who's here on this call. He was my research assistant for this project for Parents Assist. And what we did was similar to our previous speakers, we engaged with community members, with parents in Philadelphia, New Jersey, and some in Delaware, asking them, what would you like to learn about? How would you like to learn about these topics that are more pertinent to your sons? And so through a series of meetings and conversations, we were able to devise 16 scripts on how we can model for parents how to communicate and what the specific topics are that are pertinent for them. And this is essentially the website that we came up with. And these are examples of the communication focused videos on how parents can initiate the conversations and how to sustain these talks that are not very heteronormative. We have a second set of videos that were focused on the topics themselves, or the knowledge focused videos. And these ones go into the nitty gritty of HIV, STIs, of abuse, consent, victimization, and a whole bunch of other topics that are more pertinent for these specific youth. We always assume that dads would be coming home and having a conversation about condom use for pregnancy prevention. But if your son will never go near a vagina ever in his life, how do you talk about using that condom for anal sex? And so we try to provide guidance for parents on how to have these tough conversations that they might themselves not have been privy to when they were growing up as straight kids. So we just did a quick survey across the country and asked participants to rate those videos, and in terms of relatability, likability, utility, and if they would recommend these videos for other parents across the board, they rated them highly as something that's crucial. And these are qualitative feedback from some of the parents regarding the videos. I'm just going to share the top one from Dory, who has a 22-year-old son currently, but told us experiences from when the son was younger. And she was shouting in all caps that the videos were very well done with great suggestions. And she took photos of those suggestions, even if we said, please don't share this with others. We're just pilot testing this right now. And so from this project, we were able to establish that Parents Assist is a feasible and acceptable way to learn about gay, bi, and queer specific sex info and to gain those essential communication skills. So some of you folks may now be asking, well, what about families with transgender children? Surely, well, there are things that we learned from that project that can be translated for these specific families. There are very unique conditions that are not the same for families with gay, bi, and queer kids. And so this is the project that we're currently working on. It's a GIST project, or Gender Inclusive Sexuality Talks. And this is the second portion where I pulled data from our participants, from parents who are AAPI themselves. And here's our flyer. But from the experiences of AAPI parents with transgender children, they noted to us how from their own experiences growing up, sexuality was never talked about in these AAPI households. And so we have this one parent here, and she was saying, when I got my period, I went to my mom, like, what is this? And she goes, oh, wow. Okay, so you're a woman now. And I'm like, what? What the heck does that mean? What is this? And mom just smiled. That was the extent of sex communication. And from conversations we've had with other folks, it's pretty typical that there's not as much granular discussions at home in AAPI homes between parent and child about milestones to expect throughout puberty and ways to deal with your emergent emotions and issues regarding safety. Another finding that we got was that there was essentially an existence of double standards within AAPI homes for these parents. They remember growing up how the messaging for their brothers was essentially permissive in terms of trying to figure out your sexuality, while for daughters, it was more prohibitive. Do not do this, do not do that, do not bring dishonor to us as your parents. And so there was an obvious double standard at play there. And so one other participant said that she remembered when she wanted to date boys, and her parents were like, no, you cannot. You have to be 18. And she said, I might have been 16 at the time. And I was like, that's a long time to wait to date boys. That's crazy. All my friends have been dating, or they've been dating since they were 12, talking about non-AAPI peers. And my mom said, well, daddy, he remembers what he was like when he was a teenager and what used to go on. So he doesn't trust boys. And that was that. And so we see here from this anecdote, not only is there this existence of double standards, but there's almost a reliance or the perpetuation of hegemonic masculinity or the privileging of masculinity, where daddy's word and daddy's recollection of how he was when he was a teenager, I don't know, 30 years ago, is still the rule. And thus, we don't trust boys and you will not date. And there was not much opportunity there for conversations or negotiations or really healthy discussions about how it is to start dating. And then additionally, we saw some themes around non-accepting faith traditions within these AAPI participants. One said, well, oh, this was a conversation between a mom and her transgender child. And mom said, like, who are you attracted to? You know, are you attracted to boys or are you attracted to girls? Because this was a big thing within their church. They were asking to pigeonhole him as a way to accept him. My child was born a girl, so if he, after transitioning, likes a boy, then that's okay. That's still not a heterosexual relationship, but it's not same-sex thing. So essentially, this was a conversation where members of the church they belonged to were trying to justify the fact that if a child is transgender and had transitioned to their actual identity, and yet they exhibited same-sex attraction, that was acceptable because it still wasn't two males being together. And so it was very convoluted the way members of this church were trying to figure out a way to justify acceptance or keeping that family as a member of that denomination. And then one issue that they consistently have, the parents we talked to, was not having a shared life experience. And so this is essentially the discrepancy between a cisgender parent and the experiences and the concerns of their transgender children. And so Anna was basically sharing with us and said, I cannot relate. I do not have her body. I do not have her transgender experience, nor am I a lesbian. I really tried to figure that out. I'm not a lesbian. I could use more information, and I rely upon learning it from people with firsthand lived experience. The hang-up in approaching that conversation with my transgender daughter will be that I don't have the breadth of experience to share with her. And so we see here a perfect opportunity for us within the School of Nursing, and we look at it as a point of prevention, of intervention, where we can provide parental education to address this seeming dissonance between the parents' backgrounds and that of their transgender children's realities. So stay tuned on that because this is ongoing work and we're very excited about the data that we're collecting and analyzing. And then there are other folks out there who may be wondering, well, how about families with lesbian, bisexual, and queer female adolescents, cisgender lesbian daughters? And so this is another study we started doing last year during the time of the pandemic. I've got the most awesome RAs working with me. Some of them are here. I didn't pay them to give me that shout out earlier. But Shift is the project that we're working on for this specific subset of families. And here are some of our flyers that we've been providing. And I'm very thrilled to say that, and this is why representation matters. If you see it out there, then people will gravitate towards participation in research. Because while we were not consciously targeting AAPI participants, it turns out that we now have a little over than a third of our sample being AAPI daughters. And that right there, again, I wasn't keen on going into this particular subpopulation. I was just concerned about sexual and gender orientation. But it's turning out that's where we're being led to, and we just have to follow that. You know, intersectionality is a real thing, and it's hard to parse. It's hard to parse a specific aspect of your identity and not be mindful of all the others. So yeah, thank you very much. These are my parents. They're back in the Philippines, happily in retirement, but they never, ever, ever talk to me about sex. They close their eyes when I talk to them about my work. I don't even know, well, they don't close their eyes, but they're just like, oh, here he goes again, talking about sex, gay sex at that too. So, you know, thanks everyone.
Thank you so much. These were all really informative, presentations about all the different facets of health in Asian American communities. We'll now just transition to the moderated Q&A portion. And of course, just as a reminder, if anyone has any other questions, feel free to just drop them in the chat as well, and we'll get to those soon. So I guess the first question we can just touch upon is, you guys talked a little bit about this, but what is the state of Asian American health today, and where do you currently think research is lacking? Could use some improvement? And also if you could talk a little bit about the disparities in healthcare access and quality that you see for Asian American populations. And anyone can start.
I can just comment briefly on mental health issues. And so, of course, there are disparities in access and, lots of barriers for mental health. Similar to Dr. Flores' work, mental health has a lot of stigma attached to it. And so many Asian American families, especially immigrant parents whose daily lives are consumed with just, getting an economic foothold in the country. That's sort of in the hierarchy of needs, mental health is not the foremost on their mind. And that, some families might come from cultures where, talking about it, is believed to make it worse, right? Or that, somehow, like if you're focusing on it, that's sort of like, what makes it worse. And so I think there are, both cultural and immigrant factors contributing to, reluctance to seek help. And then on the other hand, there are also a shortage of linguistically and culturally competent service providers. I was just reading a article, I think that appeared in LA Times a couple of days ago about just sort of the overwhelming need for mental health services that many Asian American mental health, psychotherapists and counselors are fielding, and there's just not enough linguistically and culturally available, competent providers available for just the sheer need that's being felt by the community at this point. And so I think that just kind of speaks to the urgency of increasing the pipeline, but also making, reducing the barriers and doing community education to reduce the, barrier to accessing mental health services.
I can comment briefly as well. When I heard your question, my first thought was the Asian American health is so heterogeneous, that Asians are a vast group with lots of heterogeneity. So that's the first thing I would say. But we know generally, for example, that in terms of Asian health, citizen Asian women tend to have better access to health care compared to non-citizens, including undocumented immigrants, with lots of ethnicity differences as well. We also know that AAPI women and men live at the intersections of racial discrimination and economic injustices. So for example, Hmong and Cambodians, for example, earn an average of 61 and 57 cents compared to, for every dollar compared to white men, for example. Nepalese women make 50 cents to the dollar compared to white men. And so we have to really be mindful of, the model minority myth and how it continues to render the experiences of specific groups in particular invisible, suggesting that certain APIs or APIs in general don't need resources. We know that we do. That is also reflected in NIH and the way that NIH funds health research, right? And how APIs are so underfunded. To me, there's also kind of big statements, or like people tend to like try to oversimplify. So, the healthy immigrant effect, for example, there's still so much, people take it as a given, like, oh yeah, immigrants who come are healthier. And so, it is what it is, right? Especially related to preterm birth and low birth weight. But there's still a lot of debate around that. You need to really look across ethnicity, across documentation status, across sociopolitical experiences. And while I think about the new administration, and this is a window of opportunity, we're trying to undo a lot of the significant damages caused by the last administration. This includes things like immigration raids and public charge and refugee bans, just to name a few. But we know that there continues to be health effects because of this. So like public charge, for example, even before the law went into effect last year, there was a leak of the memo, and we know that there were chilling effects for that. We know that there continues to be chilling effects of public charge. So that's kind of just what my first thoughts. I guess in terms of your second question about like what research is lacking, to me, really thinking about the structural level determinants of social determinants of health, like that's what I want to focus on. I think that there's been some really great research, particularly around immigration enforcement and how that's impacted, particularly birth outcomes. So, how do criminalizing immigrant policies impact birth outcomes? But I'm also really interested in like, what are the inclusive policies and how has that impacted health outcomes? We actually know that the majority of policies passed at the state and county level in particular has been inclusive. So how do we focus on good policy and integration policies to actually improve health? We need disaggregated data, like Dr. Flores said as well. We need work on intersectionality and to do it in a methodologically rigorous way. Those are the things that are top on my list of what's needed right now in the field of Asian American health.
I really can't think of anything substantial to add that our previous two speakers haven't mentioned just now. I was thinking about the focused need on research and healthcare provision, or who the recipients of healthcare are, so that we can use that data to figure out who's not being served. Similarly, in research, which population is the most commonly researched one or engaged with this enterprise versus those who are, traditionally viewed as a hidden population or difficult to recruit, or are there just opportunities for our research practices to become better and more inclusive? As I think about my work in LGBTQ health, and now it's slowly moving into AAPI LGBTQ health, I'm astounded by the parallels between the previous issues with research that has been ascribed to dealing with sexual and gender diverse individuals, and now looking at subpopulations under this large title of AAPI. And it really is, it's the same complaints that we've heard, but only in a different format. And then, just as evidenced by my tiny little team that's making headway in figuring out where these, for example, the gender minority women are who happen to be AAPI. It's just a matter of focused, targeted effort for us to start uncovering what the important issues are that needs our attention. And I think us highlighting that that yes, why don't we have the same amount of funding available to us just because we might be, oh, I don't know, 4% of the population. But if you do compare the disparities between our health outcomes versus other members of American society, it certainly will make itself clear the need for these focused research or health access or implementation studies. So yeah, there's certainly a lot of work out there, which is why I'm thrilled that we have opportunities such as this discussion session. To our students who are, a lot of you are actually seniors graduating in a week or in a month. In so many ways, you have this privilege of having this education. And so the question is, how do we start relying on you or taking you into the way that into the research or service enterprise so that we can start addressing the needs of our population. I'm already pontificating, but I always throw it to members of my team. What are you doing when you get back home to California? Does the engagement stop here? But I know that's why you're here. You're interested in this kind of work.
Can I just add kind of to what Dr. Flores said, that it spoke to me so much, is that I come from a public health background and demography background in particular, where, like at Hopkins, when I was doing my PhD there, they would say things like, oh, we need more neonatal deaths so that we can have a big enough sample to do something with. And so I was actually steered away a lot of times from Asian American health research. And that's, probably not true. I feel like public health is like just behind in so many ways. But I would say to the students in listening here today, your work really matters. And even though, as Dr. Flores said, we might be a smaller population, there is gaining attention that we need this work. And so that's kind of what I wanted to just say, was your work matters, and it's important what you're doing and what you will do.
Yeah, thank you guys so much for sharing. So the next question is, how has the COVID-19 pandemic impacted Asian American health at large and the specific sectors that you work with?
All right, so since I kind of teased everyone about the data that I had, maybe I'll just take this opportunity to just quickly show you some of the emerging work coming out of our research team. So again, bear with me with my file sharing, but again, I'm actually kind of excited to share these infographics with you because, I think because of the recent spate of violence and just really atrocious racism level against Asian Americans, I've been, my collaborator Doris Tang and I've been, we've never been in so much demand before in terms of speaking to the media and various even corporate and student group settings. And so we decided to translate some of our early work findings coming out of our team using a much more kind of public friendly facing infographic. And so this is the data that we collected last December from nearly 700 Asian American adult participants across the country. And we were actually, pretty happy with the sort of the representation of Asian Americans in terms of, ethnic backgrounds, with only about half of our participants, representing East Asian. So we had, sizable South Asian and Southeast Asian participation in our study. We also, our sample skews heavily toward women, but we have a very good representation in age group as well. So, I think for many of us who in psychology who struggle to get non-college student data, I am just chomping at the bits of this data. And then we have about 57% U.S. born. 88% US citizens. Speaking of research methodology, because we only did this, we only had the time and the funding to do English language survey, that, certainly affects the nature of our sample. And, I think, research definitely needs to take that into account, but, especially if, it's for hard to reach populations, we definitely need to, have multilingual research outreach. But we also, had participants from across the 43 states. And so I'm actually talking with, I think May's colleague, Gilbert G at UCLA, to talk about, how we can take advantage of the geocoded data to understand our data. And so we, what I'm sharing is just the, frequency of different COVID-related discrimination experiences that Asian Americans adults in our sample were reporting. And this is in December, so before, when it was like a relative lull. I mean, I hate to say that because I think it's a continuous thing, but I think, before the recent spate of violence began. So even then, a sizable portion of our participants were reporting being avoided or shunned, verbally harassed or name called in person and online. So, and then about 1 in 8 were also reporting, having been physically assaulted, at least once because of their race since the start of the pandemic. And, just looking at the correlation between, different forms of discrimination and their depression, anxiety, and worry symptoms. Of course, I think what we saw was across the board, people who are reporting more experiences being discriminated against on basis of race, following the pandemic, either in person or online, directly or vicariously. They, any form of discrimination were associated, higher reports are associated with more depression, anxiety, and worry. This was especially true for younger people in our sample. And also, makes sense that it was also strongest for in-person direct attacks. And so I think what, to answer the question of how are COVID affecting, our population, in addition to, health and employment and other, direct or indirect effects of COVID, certainly we're seeing that, COVID generated racism and anti-Asian discrimination are affecting our population, in mental health.
So I can share the fact from the nursing side of things. What I want to highlight here is COVID's disproportionate impact on Filipino American nurses in the front lines. For folks who have not heard of disturbing trends in the last few months, there was a report that came out later last year, that essentially pegged the number of COVID-related deaths among nurses, where 1/3 of these deaths were among Filipino Americans. And that is just so astounding when you think about that we don't even comprise a major grouping of nurses in this country. And Andre probably has better numbers for us that he can put on the chat. But the fact that Filipino Americans are the largest group of nurses, frontline workers who are dying by exposure, is disheartening, because it speaks about the many problems that we have in healthcare right now. The way that we are, this population subgroup of AAPI folks are made to work in more, tiring and precarious situations, and how by virtue of history, we've had now multiple family members be a part of the healthcare industry, and thus increasing their exposure when they get home, or the presence of pre-existing conditions based on racism, based on stress, that they've experienced in the healthcare, in the workplace, all are compounding the risk factors, which has resulted in this very scary statistic. Um, and there's so much work in that field. And as I think about Filipino American nurses, we have a sizable South Asian nursing population as well. Back when migration happened in the 60s, when foreign workers were allowed into the U.S., these are the two big groups that came in because they were highly professional and they had the training to provide for the emergent need of U.S. Americans. And the fact that they are always consistently on the lower side of positive health from the as far as occupational health is concerned is very is an indictment to how we have not been receiving the adequate kind of support for the kind of important work that we do. Um, on a slightly positive note, or where's my share screen? Dr. Okazaki shared with you data from her recent work. I'm just going to share with you my Facebook page because I think it's highly valuable that, we remind folks in the US of the kind of engagement we've had in country building and how we take care as immigrant populations, as perennial immigrants. We actually have been contributing for the longest time to the health of America. And so blasting it out there in whatever medium you have. I'm an older person, so I'm on Facebook, but you have your other means, just normalizing for folks or blasting to them. No, we have been not to perpetuate the model minority myth, but really asserting the fact of our identity as crucial members of society and making us or removing this invisibility so that when horrible instances happen, it's not a them versus us that majority society has, but more of they can relate to our stories because we have made apparent the indispensable manner that we have contributed to society. So while I think about the research I just shared with you was very risk oriented, I also want to remind folks about our resilience, about the positive factors that are inherent with our group affinity, with our background. And that's one of the things that I like about having dedicated spaces such as this to help us come up with the language and the ways that we can make apparent our significant contributions, ongoing contributions to the country in whatever field it might be.
Yeah, and in terms of the pandemic and influencing Asian American health, like to me, there's two dual pandemics occurring right now. So there's COVID, and then there's also anti-Asian racism and racism against other BIPOC communities. My sister is an OB/GYN, and she has actually told us many instances where she's been discriminated against as a doctor. So people will come and say, like, I don't want an Asian doctor right now for no other reason than, what she looks like. So that's very disheartening to hear. In terms of reproductive health and how COVID has impacted Asian American health and reproductive health, I guess one thing that we should know is that governors in 11 states gave orders to restrict abortion care and access, deeming reproductive health care as non-essential. This should make all of us pissed. So abortion care has been disrupted in states like Ohio, Texas, Tennessee, Arkansas, and there continues to be assaults on women's reproductive autonomy. And they're just using COVID as another weapon to do that. For maternity care services, pregnancy is already a time of such vulnerability. COVID has exacerbated those vulnerabilities. So women, especially at the start of the pandemic, were unable to labor without a support person. And then that's changed kind of recently. But once they're allowed, they're now limited to the number of support persons and people able to visit. This has resulted in social isolation and increased postpartum depression, as we all can imagine. I also completed data collection recently among undocumented and kind of the social, economic, and health impacts of COVID on health. And we're analyzing that data right now. But one thing that happened, excuse my puppy, he's easily triggered. But one thing that happened last year, kind of parallel to undocumented, is the DACA SCOTUS hearings, if you all remember that. And that produced huge anxiety around the decision. And I think one thing that COVID has just highlighted is how important DACA has been for undocumented Asians in terms of accessing healthcare during a time of pandemic. It's been critical, but I think it also highlights the further heterogeneity within the Asian undocumented community, that not everyone is eligible for DACA for various reasons. And so it just begs the question is of who has the opportunity to these resources and who doesn't, including undocumented parents and elderly, right, who are more susceptible to COVID-related deaths.
Thank you guys so much for answering those questions. So we're going to open up questions to the audience now. So if anyone in the audience has a question, feel free to write it in the chat, or you can private message it to Lou and I. And also you can unmute yourself and ask a question.
And I'll just give a shameless plug for the BRAVE study as well. So that's our website, and we don't have data up from the COVID data up just yet, but we will.
Julesy?
Yeah, I have a question. First of all, thank you so much to everyone for sharing your research. It was so interesting, so thank you. I was wondering about, like, how does your work and research shift between working with local Asian American populations and Asian populations more globally? And even if you don't have like direct experience in this area, I'm still curious how you think global health can better inform immigrant health, public health, like that field. Yeah, more as a whole. I feel like immigrant health is kind of in this like in between space of like between global health and between like community health. Like here, it's like, I don't know. I'm just very curious in this intersection and how you think that research there is evolving.
I can jump in a little bit with kind of some of my work and how I've thought about it. So most of my early work actually focused on in global health settings and mostly in Asia. And I think one of the reasons why I wanted to highlight today, kind of both a global and US setting, is to highlight that those structural determinants are very, there are many similarities across both global and US settings. And that has to do with power inequities at the structural level. And that might look different, right? And the extent of it might be different for different populations, but nonetheless, they're there. In terms of kind of how I think about it, particularly within the context of reproductive health, it's interesting that a lot of the reproductive rights research has actually kind of come from the global health world. You know, the universal childbearing rights, for example. There's a lot of population kind of atrocities that have been done in global health settings that I think also applies to the US context. So, you know, things that I think about, for example, are population changes and the control of populations, right? So like in the 70s, for example, there was the whole population bomb movement and how populations have been increasing and how we need to restrict populations. And what that ended up meaning was that there were things like forced sterilizations, forced hysterectomies, IUD implantations without kind of women's consent, lots of, infringements on reproductive rights. But at the same time, those things are happening in our own backyards, right? Like that happened in California, that happened in LA at USC, where they had forced sterilizations of Latinx and immigrant communities and Black women. And so there's a lot of parallels actually. And so when I think about, I have students ask me like, should I do global or US health? And I think that there increasingly is this recognition that there isn't and probably shouldn't be a divide.
Yeah, I'll just add a few comments that, I think for me, as I've been, doing this work with, various Asian American communities, we've been, as scholars and, as policy advocates, we've been, advocating for disaggregate data and to be much more specific when it, calls for specificity, because on one hand, I think Asian American, Pacific Islander coalition makes sense from in certain contexts, and there are certainly shared experiences, especially being racialized in this country. But I think when you look at, particular contours of the community's needs and the family dynamics, you can't do this work without knowing something about sort of the global context of immigration and that particular diaspora community's connection to their families and kinship and friendship network that is in still in their heritage countries, and just sort of the migration and movement of people around the globe, I think compels us to you can't just do this work without being able to understand what's going on in the with particular communities. So just a quick example is that when I was doing the work with Korean American communities in Chicago, and we were looking at sort of like the housing patterns and real estate and where the Korean American families are locating and how that was kind of related to our questions about racialization and educational mobility. We were kind of chuckled. I mean, we're kind of interested to find that there's a real estate office in South, Seoul, South Korea, that was selling real estate in like this particular neighborhood in a suburb of Chicago that was known for high, highly rated high school. So again, I think just like knowing a little bit more about sort of the circulation of bodies in between sites, global sites, I think made us much more cognizant of being able to contextualize, and understand the experiences that are unique to that population, but kind of speak to sort of the larger truth about, what it, feels like for families to immigrate for various reasons, for economic, educational, labor, or marriage, migration. So.
I don't have any active global health work in my research. One of the things that on good days when I feel like I have control over all of the tasks that I need to be doing, I flirt with the idea of creating a new line of work back in the Philippines, where I was born and grew up in, to address HIV/AIDS outcomes over there, because sadly, the Philippines is the number 1 country in Asia that is experiencing an increase in HIV infections among their gay, bi, and queer cisgender male folks over there. And so, because my training was in by the bedside, I feel like there are so many things we've learned to do here in the States that we can definitely translate back to the old country, as I refer it. But as I started looking further into that, I realized too that the way nursing occurs in the States is different from nursing in the Philippines, where it's still very much a gendered workforce, where there are power dynamics, where doctors or male providers still have so much power concentrated, and the autonomy of nursing work over there is not the same as work over here. So having to think about those and potential barriers to the adaptation of interventions that we already have here and how it might look in a specific setting where, you know, there are power dynamics and social cultural issues that also need to be considered. It makes me pause, but I also think, you know, this is the kind of challenge that we need to have, because with sexuality still being highly stigmatized in many settings, you know, there are tons and tons of challenges to unravel and unpack to slowly make a dent in the health outcomes of those folks who are vulnerable for HIV infection. But hopefully someday, maybe one of my other RAs will continue with grad school and they can take on that piece of the work. I am just a provider of challenges is it's what's turning out to be.
Tamia, do you want to ask a question?
Yes, I have a question that I think will be relatively quick. I'm not really sure, but I was talking to my best friend, and she is Chinese American, and we were talking about specifically healthcare and how when, like, oh, you need to go to the emergency room for like allergic reaction, I told her like every time I wait 30 minutes and I think it would be cheaper to just die. Which is it's like, it sounds sad, but again, we had this conversation and she was talking about how, yeah, that she felt the same way. So this brought me to my question now. Do we have any information on insurance, especially when I think about the accessibility to healthcare? It's kind of costly to gain that type of access. So I was wondering if you could briefly speak about the role that healthcare insurance plays a role in Asian American communities. And another sub portion of that, it also might be tied to like employment opportunities. I know like some benefits, you get some benefits from where you work, but I don't know if they are tied.
So it's definitely tied. The unfortunate reality here in our country is that insurance is guaranteed, has all traditionally been linked or guaranteed through employment, whereas that model is it's not a universal model. But you know, that's capitalism for you and the way it's unfolded here in the US. I'll also say that it is so hard to navigate this web of the medical industry, the complex that it is, and insurance in particular. I am a healthcare professional. I cannot figure out how to even get started. It immobilizes me when I have to access it for my own health. And can you just imagine what it might be like for, say, members of an immigrant community or folks whose primary language is not English? And so we have right there is already access issues arise. And there, so how do you even begin to tackle the complex issue of efficient access of health? I teach a class on social determinants of health, and this is one of the perennial barriers that come up. I am hopeful that this new administration might do better for the specific subpopulations that are hardest hit by whatever health outcome it is that you're looking at. I'm sorry that you feel when you were having that conversation with your friends that in some ways it makes sense to think of worst case scenario than getting into debt to address healthcare issues. This is actually something that a lot of folks, not just AAPI folks, but other racial and ethnic minority groups have to grapple with. Do we pay for our healthcare bill, or do we pay for rent? Do we buy our medication, or do we pay for our electricity? Again, so many issues, and I can't provide any solution. Not only is it not part of what I work on, but I'm defeated by it, to be honest.
I completely agree with all of that. And just to say that for the undocumented population, the Affordable Care Act, increased health insurance coverage to, I think, about 30 to 35 million people, but it still excluded purposefully the 11 undocumented immigrants in the US. The DACA, for example, allows, I think that it's like different by state. So in California, for example, in 2020, well, DACA has been allowed to be on Medi-Cal, but in 2020, I think that they actually expanded the eligibility criteria to all undocumented within a certain range. But that still is pretty restrictive in terms of age groups, right? We're not talking elderly undocumented. In regards to, there's also kind of restrictions even for immigrants who are, legally here. So you have to, for example, the 5-year bar, you have to be here for 5 years in order to access public health insurance. That's for pregnant women in many states. They've actually removed that 5-year bar, and it goes all the way till 60 days postpartum. In COVID, it's been really interesting because no one's been allowed to be kicked off of Medicare. So undocumented who, got on Medicare because of pregnancy has actually continued on in certain states. And so there's some really interesting kind of natural experiments that we could look at there. But we know from data that being able to have health insurance as an undocumented for pregnancy has reduced, population level adverse outcomes. So for example, preterm birth and low birth weight. NAPOF is working on some interesting kind of policy and bills around the HEAL Act, which I think is trying to advocate for removing the 5-year bar for immigrant families.
Yeah, and I'll just add that, I think when we ran our study with Asian American adults for the COVID study, I think about 9.2% of our sample were reporting that they were uninsured, which I think is comparable to the US population. So certainly I think within the Asian American population, it's, they're affected by this just as much as the rest of the country. And I think this, we found this to be true, especially among certain immigrant families who are small business owners or entrepreneurs, and they just can't afford to buy themselves health insurance. So I remember during our data collection, as we were visiting families, that they would just often say, we're just kind of hoping that we stay healthy. And that there was a one family where the mom had an accident and she had probably like 5 years, took her 5 years to pay back the medical bill from that one emergency visit. So again, I think our, communities are affected by the inequities in the healthcare access system.
So we have time for one more question. So again, you can just put it in the chat or you can unmute and ask it out loud. Yeah, Jaewon, do you want to go?
Yeah, thank you so much for speaking today. I think not to discount the insane public policy that needs to be enacted in response to all of the problems that we highlighted on like the state and federal government level, but do you think there's meaningful action that can be taken from maybe like within the Asian American community itself when it comes to the fight for health equity? And people who are not directly involved in government or maybe like not researchers, et cetera.
So I think I'll just restate what I said earlier about the power of us humanizing to the larger population, our backgrounds, our families, our narratives. as non-researchers or as non-policy folks. We are at an inflection point, I think, in AAPI history here in the country. I am inspired by a colleague who has started in the last 2 weeks to be really mindful in sharing unfortunate incidents that she's had growing up in the country and as raising a family. I think she is doing this I know she's doing this methodically so that she can reach a wider audience, for folks to start getting to know us more beyond, the typical things that one sees on social media. And I think, again, harping back to you folks using your pen privilege, if you're anything like me, and I suspect that you are, you come back to your home communities and you're regarded as slightly more special because of what you have achieved so far or the training that you've received. And I think leveraging that to be a platform for people who may not be able to express their concerns, their needs to a wider audience, is a great way to make a significant impact, from a grassroots level. Especially as we talk about undocumented immigrants who don't have that privilege out of fear for their security, out of fear that they may be deported or be on the receiving end of violence, perhaps. For those of us who have aspects of our identity that we can use to extend to assist others, I think it's very powerful. It's very corny, but I know I'm a corny person. But this is how we start. Take a page from the LGBTQ movement. I feel like in the last decade, this is how it had made strides in making the idea that it's a scary, nefarious population to now there's more social acceptance. Perhaps we can use lessons learned from that movement into our own AAPI community.
Yeah, and just a plug, I think, as researchers or as, those of us who have access to the data about AAPI community, that, there are ways to partner with, community-based organizations that advocate on behalf of the community. And, they can use our help as partners in, testifying in front of local governments that make the local regulations that actually make a difference in everyday lives and things like that. And so certainly I think there are many ways in which you can influence, and telling stories that are impactful to policymakers, bringing the data, bringing our kind of collective knowledge, I think can make a difference at city and state levels in ways that might feel difficult to do at the federal level.
I don't have much to add beyond that, except just to amplify as well what Dr. Flores said in terms of, and Dr. Okazaki, what she just said in terms of just sharing your stories and speaking up. And something that's kind of stuck with me is, an email that I got from Tung Nguyen, and he kind of shared this out with a group of Asian American researchers, but basically saying, when I talk about this, don't let me be the only one that talks about this. Amplify what I'm saying so that I don't feel alone talking about it. And that just has kind of stuck with me because I, in the past, have been someone who, if someone says it, I'm like, oh, I'm so grateful that person said it. But I tend to be very introverted and kind of scared to speak up. And so that stuck with me because I think it's just, made me realize like I need to back up that other person who's speaking as well. And it's, beyond just research, right? Like one thing that I've been really heartened by is all the journalism and media coverage, particularly among Asian American women in relation to the Atlanta shootings, and just the ways that they've been doing it in a more nuanced and thoughtful way. And so I, pay less attention to kind of like the national coverage and focus on these voices who are doing real justice to these stories.
Yeah, thank you guys so much for answering that question. So this concludes our panel for today. Thank you so much for participating and sharing your research with us. We're very inspired by your work and appreciate your contributions to Asian American Studies research. And thank you to Sumi for discussing the mental health of Asian Americans and your recent COVID study. I found that very interesting, and I'm actually going to be completing my psychology honors thesis next year. And when I was brainstorming potential project ideas, I was thinking about how the mental health of Asian Americans has been affected due to COVID and the rise in anti-Asian violence and attacks. So I found that very interesting. And thank you to Dr. Flores for joining us today from Penn, our institution. It was great to hear about your experiences and research on the sexual health of Asian American and LGBTQ plus individuals. And we also loved how you are the faculty advisor of APANSA. And I think we actually have a few members here with us today.
Yeah, and thank you so much, Dr. Sudhinaraset, for going into all the details about reproductive health and just like mistreatment during childbirth in India, and then how those points relate to, Asian American and Pacific Islander populations here. When I was doing my thesis on C-section rates in India, so a lot of this stuff about everything you talked about and the parallels between America and Asia were things that I personally focused on as well. So that was very informative. Yeah, and if any of you have any announcements you'd like to make, please go ahead. But I know in the chat there were some links to the NYU project as well as the UCLA study, and then Dr. Okazaki's book. Please check it out if you have a chance. But yeah, if anyone else has anything else, please jump in. But this is the end of our discussion. Thank you so much again.
Yeah. And also, I saw a question in the chat asking about if there's a recording. So this will be posted probably in a week or so, and it will be on our ASAM website.
Thank you so much.
Thank you, everyone. Thank you so much to our guest speakers too. It was really wonderful to have you. I mean, I've learned so much in this very short amount of time. I'm also really angry too, just listening to some of the research and the results, but thank you so much for sharing it. And if you have any questions, don't hesitate to reach out to me or to Annabelle.
Thank you for organizing this space.
Bye, everyone.